This lecture is about gout. We'll be looking specifically at acute gout. So gout is a systemic metabolic disease. And basically, it's a very common inflammatory arthritis. There are 4 clinical stages. There is asymptomatic hyperuricemia. There is acute gouty flares. There is intercritical gout or intermittent, and chronic tophus gout. The epidemiology of this common inflammatory arthritis is about 8.3 million adults in the U.S. have gout. That makes it about a 3.9 prevalence. Unfortunately, prevalence increases with age. 10% of men aged 70 to 79 have gout, and 6% of women aged 80 or over have gout. The pathogenesis is quite complex, but I tried to break it down for you. It's basically sustained hyperuricemia is a risk for gout. Most patients with hyperuricemia will not have a gout flare. Isn't that interesting? However, those that do certainly are not in good shape. Uric acid production is increased in males after puberty and in females after menopause. And most cases of that hyperuricemia are caused by undersecretion of urate by the kidneys. So that's the bottom line on the pathogenesis. 73% of all gout patients have mild to severe renal insufficiency. So this could explain it. Clinically, your patient will present with acute gout with a history of rapid onset and a buildup of pain. The first flare often occurs at night and wakes the patient up. They have pain, warmth, redness, swelling, decreased range of motion in the affected joint. And usually it's monoarticular in men, so just in that one joint. Interesting, about half the people, their initial gout flare will be in the first metatarso-pharyngeal joint, which is the great toe. Okay, so half of them. Then in descending order, instep, heel, knees, wrists, fingers, and elbows are sites that are common. Systemic signs of acute gout are fatigue, fever, and chills. Diagnostically, the only definitive way to diagnose gout is through a needle aspiration. And they're looking for those crystals, okay? But we know that in primary care, that's not always a reasonable thing to do. We don't have very good access to rheumatologists because we don't have enough. And some of us are not trained, or if we are trained, not so much it's difficult to get the aspirate, but then those samples have to be worked up and taken to the correct lab, and they're expensive and timely, so lots of different reasons, but the gold standard is that aspirate. About 95% of patients will have the monosodium urate, the MSU crystals present. And interesting, when you do a serum urate level or uric acid level, it's positive in about 51% in an acute flare, which means it's negative in 49%. So that's a little misleading, and that's why it's not the gold standard diagnostic tool. Ultrasound can be very helpful, as well as dual energy computed tomography or DEC, because it can really focus on those crystal deposits and analyze them. It's expensive though. So management of acute gout. There's 3 types of gout therapies. There's one to treat an acute flare. The second is to lower the total body uric acid pool. And the third is anti-inflammatory prophylaxis to prevent flares. However, we cannot negate the importance of non-pharmacologic interventions, which would include diet, reducing your caloric intake, avoiding alcohol or at least limiting it, increasing low-fat dairy's been found to be beneficial, and either eating or drinking cherry juice. We do also know that it is beneficial to rest a joint for 1 or 2 days, and resolution will come quicker, and cold application can help. Treatment of acute gout is reviewed in detail on page 930. You can refer you to box 176, okay? And basically, I just put a few words here. The best thing is to confirm via needle aspiration. Often non-steroidal anti-inflammatories are the first line of treatment. If they don't work, then sometimes systemic steroids are used. We can also use oral colchicine, but it has to be within 36 hours of onset. And it also has to be used cautiously because of toxicity. So we can also inject if you have more than one, or if you have 1 or 2 joints, you can also inject some intra-articular steroid. One of the things we've got to emphasize is don't start or stop urate lowering therapy during an acute flare. So who do we refer to? Ideally a rheumatologist, but that might take months, but it's worth it. So to have their expertise. And then just remember, hospitalization is rarely necessary, not for an acute flare of gout, even though you might, if your toe or heel might hurt that bad. Patient and family education is again saying there's some real value, the best value in a gout diagnosis being obtained through needle aspiration. Educate them on the 3 types of treatment for gout: medicines to control flares, prevent further attacks, and help lower that uric acid pool, and then how important lifestyle changes are with weight control, limiting alcohol, a low purine diet, so not too much fish and meat, especially organ meat, gravies, increasing low-fat dairy again, and then eating cherries or drinking cherry juice has been shown to reduce gout flares. Thank you very much.